Okay, so welcome everyone to the video. Today we are talking again with Angie Nichols. Welcome, Angie.
Thank you.
And today she has prepared for us a really nice talk about the Polycystic Ovarian Syndrome, PCOS. Okay, start your talk, Angie.
And if this is your first time here, make sure to subscribe so you can learn more about fitness and nutrition, hormones and anti-aging, all this to optimize your life overall. And hit that notification bell so you don't miss anything.
All right, I'll be happy to, Stephen. Thank you for having me. So PCOS, also called Stein-Levin-Hall syndrome or hyperandrogenetic anovulation, is a very complex disorder. It is a endocrine disorder among reproductive age women. Here's a few statistics about PCOS. It is an ancient disorder, first described by Hippocrates. Symptoms of PCOS have been documented among women for more than 2 millennia. Interestingly, Hippocrates documented that female patients having less than 3 days, also having a masculine appearance, and were subfertile. Serenus of Ephesius noted that it is normal for women not to menstruate, and that women who do not menstruate tend to be more masculine and robust. Physicians have described a combination of signs throughout the times, including menstrual irregularity, a masculine body type, subfertility, possibly obesity, which is suggestive of PCOS. So 1 in 5, and these statistics are highly variable depending on what source you look at, anywhere from 1 in 3 to 1 in 8 women supposedly affected by PCOS. The World Health Organization in 2012 estimated that about 116 million women have PCOS worldwide. And some articles suggest that the number of women are underdiagnosed as much as 70%. And the reason for the lack of adequate diagnosis is because the diagnostic criteria are very unclear. And depending on which criteria you use, the prevalence rate can be doubled. So that's what makes this very challenging for practitioners to make the diagnosis. Okay. So the etiology of PCOS, it's highly debatable as well. There are many theories, but there is an abundance of research that shows clearly that PCOS is genetic. There are genetic variants that have been associated with PCOS. There are non-genetic factors such as activity and nutrition that can influence the development or severity of the disorder. So although it cannot be cured or prevented, the severity of the symptoms can be reduced by lifestyle factors. So here's a little bit of a diagram that will show you part of the complexity, and this isn't everything. I've tried to make it as concise and clear and condense it in a way that's easy to understand, but this sort of demonstrates how complex PCOS is. So there's a defect in the pancreas, and as I said, there are a lot of genetic components that go into it. So a decrease in the a defect in the pancreas will lead to hyperinsulinemia and insulin resistance secondary to genetic factors. So there are multiple underlying pathophysiologic mechanisms involved with PCOS, and several theories have been proposed to explain the various pathogenesis of PCOS. We know that there is an alteration in the gonadotropin-releasing hormone results in an increase in LH. So a defect also in androgen synthesis results in increased androgen production by theca cells within the ovary. So we have insulin resistance, which will then cause an elevation in blood glucose. So when blood glucose goes up, the pancreas begins to produce more insulin to counteract it. Well, when we have high levels of circulating insulin, that's going to change or cause a cascade of events. So the hyperinsulinemia will cause an increased sensitivity at the hair follicle, which will then lead to hirsutism or hair growth, and then acne as well. It will also decrease the production of T3, which will then decrease metabolism and increase the visceral body fat It causes fatigue and, all the symptoms that go along with hypothyroidism. So we typically will see symptoms of hypothyroidism in women with PCOS, and that should always be considered when you have a premenopausal woman or reproductive age woman that has symptoms of hypothyroidism, that it may be a result of PCOS causing it. So at the same time, a high level of insulin causes a low level of sex hormone binding globulin to be produced by the liver. So when we have less sex hormone binding globulin, there's not as much to bind to the free testosterone, which is going to cause an elevation in testosterone levels, free testosterone, which is then going to aggravate or exacerbate acne and hair growth. So then we're also going to have, because of low sex hormone binding globulin, an elevation in estradiol. So when we have an elevation in estradiol, and as I mentioned earlier, a decreased production of progesterone, that's going to cause the endometrial hyperplasia or buildup of the uterine lining, which can then lead to endometrial cancer. So if PCOS is not diagnosed and addressed early, then the long-term health consequences are very severe. So that's why it's so important to diagnose this early. But unfortunately, because oftentimes women don't have severe symptoms when they go to their doctor, and it's kind of vague and they can't put it together, it goes for years being undiagnosed, and then we end up with women having cases of endometrial cancer, breast cancer, and things like that. So screening for women really should begin within about 2 to 3 years after they begin their first menstrual cycle. Okay, here's a few more things that happens with PCOS. In PCOS, we have anovulation. So we're not ovulating each month. There's lots of menstrual irregularities, and these were identified, like I said, back in ancient times. When we don't ovulate, then there is less production of progesterone, because when the follicle ruptures after ovulation, that's where the progesterone comes from. So again, that will increase the risk of breast cancer and endometrial cancer, this lack of progesterone. Progesterone is also a calming, mood-stabilizing hormone, and so we need it to help manage anxiety. Women that have PCOS have a higher incidence than the average population for anxiety and mood disorders. Also, having lower thyroid production is going to also play into anxiety and mood disorders. As you know, a lot of psychiatrists use high-dose thyroid to treat anxiety and depression. And then PCOS can also cause adrenal hyperplasia, which will increase the total testosterone level, aldosterone, DHEA. And this will again add to the problems with the skin, acne, and hirsutism. So in 1935, Stein and Leventhal, a couple of gynecologists, described the following features, and this was our first diagnostic criteria, and it was described as hyperandrogenism, menstrual irregularities, polycystic ovaries, and central adiposity. Few of these are now considered consistent findings for diagnosing PCOS. 50% of women that have PCOS will have polycystic ovaries, 50% will not. And because the severity of these symptoms can be reduced or minimized by things like activity, they may be mild, but it's not changing what's going on at the cellular level. It's not changing that insulin resistance. That problem is still there. You just may not see it outwardly. Here's a study that shows women that have PCOS will have a flip in their FSH and LH ratio. Normally, the FSH to LH ratio is 2 to 1, meaning your FSH should be 2 times higher than your LH. When you see this split, this is very indicative of PCOS, but yet it's not included in the diagnostic criteria that is used presently to evaluate PCOS. So here's another piece of the, and I refer to PCOS as just putting pieces of a puzzle together, because there's no one diagnostic thing. It's not like seeing an x-ray and you say, oh, that bone is broken. There's just a bunch of pieces that we have to put together until we get a picture of what it is. So this was a study that was done where 19 loci were associated with PCOS identified in genome-wide association studies. And this is as recent as, I believe this study was 2019, that they have now identified evidence of the presence of a male phenotype for PCOS. So you can not only pass it down from the mom to the daughter, but also it could be passed on through the father. Okay, so here's more pieces of the PCOS puzzle, and you can see how many different symptoms they are. And so women can present in many, many ways. I've had women come in and say, I ended up in the emergency room with super severe ovarian cysts that were rupturing and pain, and the ER doctors told me if we didn't know better, we would think that you had PCOS. And this was a nurse, and she said, well, why do you think that I don't? He said, well, you're not overweight. You can't have it. Well, 50% of women that have PCOS will be lean. You don't have to be overweight. You can manage that, depending on the severity again. So hirsutism or hair growth, it can be facial or body hair growth. That's always a red flag. Women that have heavy periods or a lot of difficulty with periods, real severe cramping or heavy bleeding is another symptom. Of course, we talked about anxiety, thinning hair on top of your head due to the decreased production of T3, the mood disorders, elevated lipids. That should be a red flag anytime that's identified, and that will lead to cardiovascular disease. Another major reason that we need to find these cases and be proactive in addressing them. Fatigue, that's going to be caused by the low production of thyroid. Also, you can see skin tags or dark patches of skin. That's due to the insulin resistance. You see that oftentimes in patients with diabetes as well. Ovarian cysts may or may not have them. Headaches, that's due to a lack of progesterone. Acne is a classic sign. Usually it's irregular periods that they will experience, depression, hypertension, and the flipped FSH and LH ratio. The PCOS women will have more difficulty losing weight. We tend to crave carbs more than the average population due to the insulin resistance. And usually, most cases of PCOS are diagnosed when they start to struggle with infertility. So that's one of the ways that PCOS is identified. If the woman has difficulty either getting pregnant because she's not ovulating, or because she can't sustain a pregnancy because of a lack of progesterone, and then she will miscarry. So another big reason that it's important to address these is because we want to spare women the suffering that will go along with infertility. It is the leading cause of infertility among women. And some things that I've read about PCOS is it's not as much infertility as it is subfertility. So we can correct many of these things if we discover. But I've had several women that will come and say, they have been through IVF and all these things, and then we come to find out they did have PCOS, but it was just never identified. So let's see, and we have that. So as I said, 50% of women that have PCOS will have cysts, 50% won't. However, this is one of the defining criteria in all three of the major criteria. So the National Institute of Health lists ovarian cysts, that women must have that in order to get the diagnosis. And I had a slide, it's disappeared, that had all three of the different diagnostic criteria. And there's just three things that they look at, and it's signs of hyperandrogenism and polycystic ovaries. Let's skip this one. Okay, so the long-term risk, like I said, it's the long-term consequences are what we want to really try to prevent, because if you look at these, they're very severe consequences and can dramatically alter the quality of someone's life long-term. So fatty liver is common in women with PCOS, anxiety, obesity, which the obesity then can then exacerbate depression. So a lot of these symptoms will only exacerbate another one. Cardiovascular disease, decreased bone mineral density, low thyroid, elevated lipids, the endometrial and breast cancer, sleep apnea, high blood pressure. So, treatments for PCOS. Lifestyle modifications oftentimes are all that is needed. We can, decreasing the amount of carbohydrates, increasing lean protein, avoiding processed foods, those can oftentimes correct the problem by itself. There's no cure for PCOS, but we can affect the severity. Metformin is oftentimes needed for women. Also, thyroid, of course, progesterone supplementation, spironolactone if she has skin issues like hirsutism and acne. And there are other options available. It really depends, and this is why women are so challenging when treating women, is because there's a lot of things you must consider. It depends on the goals of the patient. If the patient wants to become pregnant, if they don't want to become pregnant, the age of the patient. So there's lots of things to consider when looking at a woman with PCOS.
Okay, that was very clear. What would be a better name for this disease, since the polycystic ovaries are not always so present or a thing in this disease?
Well, I think it should be something related to insulin resistance for sure. Maybe a female insulin resistance syndrome or something along those lines, because the name is so misleading, and oftentimes if they don't have the polycystic ovaries, it's just discounted. Oh, you can't have that. You don't have ovarian cyst. So I have it myself. I did not ever know it until I got older because I was always very active and, stayed very lean. But then as you become older, more sedentary, and insulin resistance naturally goes up anyway, the symptoms become, a little bit more obvious. And then also it's knowing what you're looking for. So 50% of women that have PCOS, their daughter will have PCOS. And so I was able to identify it in my daughter very early because I knew what to look for. And so, but when I took her to her pediatrician to present, we did the lab work, and she had the classic, and depending on the FSH LH flip, that will tell us severity also. So a 2-to-1 flip is pretty indicative of PCOS. Well, she had a 3-to-1 flip. And so when I took her to the pediatrician, she's like, well, why would you have even tested the FSH and LH? She didn't have a clue. The literature's all there. It wasn't her fault, but they just don't have time, and it's not high on the priority list. They're busy with vaccinations and the latest, bug that's going around and things like that, developmental delays and things. So it's a lot more prevalent than what we're aware of.
Is there a link with diabetes type 2?
Absolutely. That's a big reason that we need to address this earlier. We want to prevent the cardiovascular disease. We want to prevent diabetes. We want to prevent the breast cancer and endometrial cancer and the obesity and the depression, which, each of those symptoms then can lead to more problems. With diabetes, then we're looking at kidney problems and neuropathy and a whole host of things, lose your vision. So we want to try to maintain the best quality of health for as long as we can. And that's what preventive medicine is all about.
Mm-hmm. Can one compare it to a similar disease in men?
Not really.
Because as I understand it starts out with insulin resistance.
Insulin resistance, and we know there's a genetic link. We know for sure that it is genetic. So, there are, I think, genetic reasons for men to have low testosterone. But as far as anything that I could compare it to, I don't know that answer.
Mm-hmm. Maybe one last question that I find interesting. Are there certain races or types of people who are more prone to it in their women? As I know there are certain types of races of Indians that are more prone to type 2 diabetes. That's why I'm asking.
Yeah, that's the interesting thing. There's really not. When I was doing some research on that topic, what we see is it seems to be the same across all populations. And because it is an ancient disorder, it's, traced back many, many years. And it seems that it's present everywhere. There's been tons of studies. One of the studies that I had was from Turkey. There's lots from Australia, well, all over really. And when I was studying looking up some things for this too, I found it very interesting. We think of PCOS as a really, difficult thing that should be addressed because the long-term health consequences can be really bad if it's not addressed. But they were saying in the ancient times, some of the things that go along with PCOS actually would have helped a woman to be able to survive the difficult environment of, say, Paleolithic period. And because they weren't having as many children, not saying they couldn't have children, but just not as many. So they, if they had one child every year during those really rough times, that would not have been a very healthy situation for a female. So they had fewer children, and this was one of the arguments that some of the researchers had said, that they could devote more time, more care, more attention to the child. And because there were fewer children, there was fewer burden even on the males. The males were less likely to abandon the family. Also, because of the insulin resistance, they were able to do better in periods when they did not have food on a consistent basis. And because women with PCOS tended to be more sturdy and more masculine because of the elevations in testosterone, then they could tolerate some of the harsher conditions more so than women that were not. So it was very interesting to read that. But it says, no, pretty much it's across all. There's not any population of people that's more likely to have it. And that was the argument. A lot of people wanted to attribute it to the processed foods and, sedentary lifestyle of today, but that's not really the case. It is genetic, and they say that's why the genes have, been able to survive all these years, is because it was providing, its dominant genes that were providing beneficial effects for a long period of time. Not so much now, but back then it was beneficial in some ways.
Mm-hmm. Yeah, very interesting.
One theory, and it made sense.
Yeah. Okay. No much of processed sugars in the Paleolithic times, of course.
Yeah, that's one thing we can't blame that on.
Sure thing. Okay, thank you so much, Angie. I learned a ton. Thanks a lot.
My pleasure.
I'm sure our viewers will enjoy this one as well. They sure will leave some questions under the video on YouTube. And as always, you're welcome to address them.
And I will. I certainly will.
Thank you so much again, Angie.
Thank you. Have a good day.
Bye-bye. Talk to you later.
All right. Bye-bye.